Good afternoon, and welcome to this webcast of the Methodist DeBakey Cardiovascular Journal. I'm Mike Quinones. I'm the editor-in-chief of the journal, and we put a webcast for every issue that we have of the journal to try to give you a little bit of education related to that topic, but more importantly, to try to get your interest motivated to actually come to the journal and read the articles in more depth. And it's very easy. You can either do journal.houstonmethodist.org or Google Methodist DeBakey Cardiovascular Journal. It comes out pretty easily. The topic for the current issue of the journal is women and the heart. A very important topic. I remember when I trained in cardiology, we treated women like men, everybody the same, other than, of course, the cardiovascular diseases of pregnancy. But other than that, we thought that there was not a big difference. The heart is the heart, the anatomy is the same. But luckily, in the last 20 plus years, we've learned that that's not the case. And hopefully, we'll convince you of that, and as I said, make you more interested in coming to the journal and reading more about it. I'm completely indebted to one person for the production of this issue, which is a very, very educational issue, very well written. I'm indebted to all the contributors. You're going to meet some of them today. But most importantly, to Dr. Valeria Duarte, who is sitting at my left. Dr. Duarte is a rare animal. There are not yet too many of them around. We hope we will increase it. But she is a fully trained cardiologist in adult congenital heart disease. A very important area because clearly there's a lot more adults with congenital heart disease and not enough physicians with the expertise. She's also an expert in diseases of women, and she was very generous with her time and took over the project of putting together this very well done and beautiful issue. So without any more delay, I'm going to put Valeria in charge. She'll introduce the other speakers and get us going.
Thank you so much, Dr. Quinones, and thank you for the opportunity to bring some more attention and make some more noise about this very important part of cardiovascular disease. I think it didn't receive enough attention for many years, but thankfully due to advocacy, education, and all the passionate cardiovascular providers who have an interest and have devoted their career to further the research and also improve the clinical care of women with cardiovascular disease. I think we have made a lot of progress over the last few years. So without further ado, just the Methodist DeBakey Cardiovascular Journal has had an issue before on focus on cardiovascular diseases in women. That was back in 2017. And we talk a lot about prevention and secondary prevention, and so we wanted to make this issue slightly different and focus in all the spectrum of a woman's life cycle, and also we wanted to highlight cardiovascular disorders of pregnancy. So we covered hypertensive disorders of pregnancy, valve disease during pregnancy, complex congenital heart disease during pregnancy, aortopathies, management of aortopathies during pregnancy, and also we focus in cardiomyopathies in women, pulmonary hypertension in women. Dr. Kurlmeyer wrote a very comprehensive article on ischemic heart disease throughout the women's life cycle. We cover primary prevention in women of cardiovascular disease in women, and then Dr. Velarde, who joins us here today, highlighted the sex disparities in cardiovascular disease. So we are honored to have some of our authors here with us today. First, on my right, we have Dr. Hobday. Dr. Hobday is a high-risk obstetrician and gynecologist here at the Houston Methodist. He is one of the most active members of our cardio-obstetrics team. We're very thankful for him and his support, and he supports the highest risk pregnancies that we care for here at Houston Methodist. Here to my left, I have Dr. Carla Kohlmeyer. Dr. Carla Kohlmeyer is the president-elect of medical staff here at Houston Methodist. She's also the medical director of cardiology. She's a non-invasive cardiologist who has devoted many years of her career to the care and research of women with cardiovascular disease. Online, we have very special guest, Dr. Gladys Velarde, joins us all the way from the University of Florida. Dr. Velarde is going to be discussing sex disparities in cardiovascular diseases. I invite you to read her article. It's very hard to summarize this topic the way she did. And then I have my colleagues, ACHD and cardiobstetric specialists, Dr. Sora Rajpal from Ohio State, and Carla Rodriguez, who was my colleague in Boston, and now is starting. She has taken on the big challenge of starting an ACHD program in the Caribbean, in ACHD and cardiobstetrics. So, Dr. Quinones.
Okay, so I'm going to get this rolling with a very common disorder, hypertension. Hypertension exists everywhere, in every room, in every house, in every country, in every city. By the time you hit the age of about 65 to 70, 2/3 of the population has high blood pressure, including myself. So as cardiologists, we think we know this very well. But it turns out that hypertension during pregnancy is a little bit of a different disease. Number one, it may be the very first time a woman develops high blood pressure. Prior to that, maybe she never had it. Number two, it may present in different ways. It may have different outcomes and complications, and importantly, differences in how we treat it in terms of drugs. So I like to ask Dr. Hopday to kind of get us through that one. How common is it? And give us a few of the bullet points of what we as cardiologists should know when we have a young woman who is pregnant and with a high blood pressure.
Absolutely. First of all, thank you, Drs. Duarte and Quinones, for inviting me to do this. I'm very impressed by this journal, and it's near and dear to my heart. The thing that we know, that we all know, is things like hypertensive diseases are on the rise across the world. There's many comorbidities as to why. For something when we're specifically talking about pregnancy, we know that the numbers also are on the rise, and we're upwards for our world is seeing, more than 15% of patients have some sort of hypertensive disorder during pregnancy. The major thing that I think is most important about hypertensive disorders in pregnancy is the correct diagnosis. We need to know what we're dealing with. We need to know if we're dealing with if this is a chronic hypertensive versus preeclampsia versus something else. So our major loopholes are, number one, we want to optimize somebody ideally before they get pregnant. So if they have any comorbidities, try and get them optimized before they get pregnant, have them on the right meds. For us, the diagnostic criteria that we use is the 20-week mark. So somebody who comes in or who's presenting that has elevated blood pressures, and for us, our bar is 140/90, then if this is prior to 20 weeks, then we're going to typically label them as a chronic hypertensive versus preeclamptic. But we know with chronic hypertension, your risk of developing preeclampsia is significantly elevated. The reason why we use the 20-week mark is because by the second trimester, your blood pressure should reach a nadir. So anytime we see hypertension prior to 20 weeks, it's kind of a red flag for us. In pregnancy, we have typically or historically used the value of, or the blood pressure of 160/110 before we started medications. But now our governing body, which is American College of Obstetrics and Gynecology, is starting to move towards using 140s/90s. For us, the meds that we're most commonly using for chronic therapy is going to be either Procardia or Labetalol. That's what we have the most data on, and it's what we're most comfortable with. So that's what we'll try and utilize, trying to keep somebody what we call below 140/90, which is what is the mild range for us. We still use classic terms like mild and severe. There's not a lot of other data as to absolutes in pregnancy, but we do know that what we have the most on is that for somebody who we think is at high risk, somebody who's chronic hypertensive, somebody who we are concerned that will develop preeclampsia, they've had it in a prior pregnancy, we're worried about their blood pressures going up, is we start them on a low dose aspirin, so 81 milligram. Ideally, we started between 12 and 16 weeks, and then we keep that going throughout the pregnancy. And then we continue to adjust medications as we need. And it's important that we keep this fine blood pressure range because it's going to eventually determine when we deliver.
What's the protective mechanism of the aspirin in these young women?
That's a really good question, and I don't know if I have an answer for that. I don't know if we really know, but it's. I mean, obviously the aspirin aspect to it.
It has impacted the outcome. There's
yes,
data on that.
we have shown that it reduces the risk of developing into preeclampsia.
Interesting.
So that we will keep managing, and then as we get closer to term, one of the more difficult things is somebody who's a chronic hypertensive that now has increasing blood pressures and trying to make the diagnosis of superimposed preeclampsia. So we see chronic hypertensive preeclampsia quite significantly in our population. And so that's kind of the nuts and bolts that I would like people to know, is getting the right diagnosis and knowing the basics of what to treat with.
Are there some medications that are kind of no-nos because they can affect the baby or affect the mother?
Very good question. We typically will avoid the ACE inhibitors, ARBs, because it can be teratogenic and definitely will also affect amniotic fluid. So that's why we try to stick to labetalol and Procardia, which we know the most about.
So a chronic hypertensive doing well with those drugs, now become pregnant, you have to take them off and switch them to labetalol or not.
Ideally, yeah.
Ideally.
That's why we hope patients are in the system so then we can manage them and optimize them before they get pregnant.
Now, if you have switched them and the blood pressure does not well control, what's your plan B when the first two drugs that you like to use are not doing the job?
We will.
Where do you go then?
That's not a common. I mean, by the time you get to maxing out Procardia and you get to maxing out labetalol, because we use them in conjunction.
Yeah.
You're probably going to be in an ICU at that point.
Oh, okay.
So for cardine drips and things like that. I mean, it is not a common time for it to be. I mean, it's not a common thing to get to that point that we can't control.
So most of the time, those two drugs will do it.
Yes.
Yeah. Very good. Very well. That's great. Very educational. Read the paper. You learn more. Dr. Duarte.
Yes. So
That was great.
Dr. Rajpal, who, as I said, joined us from Ohio State University, he and Dr. Rodriguez wrote a very comprehensive paper on high-risk congenital heart disease in pregnancy. This is a group of patients that is very challenging. I would say one of the most challenging to manage. So, Dr. Rajpal, a lot has changed over the last few decades for patients with ACHD and for women in childbearing age that are now surviving into adulthood. So, can you share with us what's the spectrum of ACHD patients that you see in your cardio-B practice, and how do you manage to re-stratify this very heterogeneous group?
Thank you, Dr. Duarte and Dr. Quinones, for the invitation to this webcast and the opportunity to write this chapter and the word limit that you gave us on such a comprehensive topic. Thank you for that too. But yeah, coming back to the spectrum of ACHD diagnoses that we see in our cardio-B, what is important to understand is several things have changed. One, a number of women with complex congenital heart disease are surviving to reproductive age and becoming successful in carrying pregnancy to term, which is an important development. So as far as the spectrum goes, we see patients very similar to some of the registries that we quote in our paper, the CARPREG registry, the Zahara registry, The spectrum ranges from very simple congenital heart diseases like small ASDs, or to moderate complexity congenital heart diseases such as tetralogy of Fallot, and even more severe congenital heart disease such as transposition of great arteries with systemic right ventricle, Fontan circulation, and on the more extreme side, patients with unrepaired congenital heart disease and Eisenmenger syndrome. So we see a wide spectrum. What's important to note in this wide spectrum, and we say this in our paper as well, that even though patients with complex congenital heart disease or high-risk congenital heart disease form only 15% of these registry patients, and I think our experience in clinic is very similar, only 10 to 15% of cardio OB patients with will be these complex congenital heart disease patients. But these are the group of patients with complex congenital heart disease that have the most complications, that have the most number of maternal as well as fetal complications and OB complications. So a minority of patients seen in clinic will have the majority of complications that are seen. So that's one important thing to note. So when you compare outpatient to inpatient setting, in the outpatient, we'll have a very wide spectrum of patients. But on the inpatient setting, you'll have these more complex patients who you will see in the cardio OB practice. And talking about risk stratification also has changed, and even what we understand about congenital heart disease classification has changed. As you know, when the 2018 ACHD guidelines were published, they classified congenital heart disease differently from the previous guidelines in terms of anatomic and physiologic complexity. So there is anatomic complexity, which classifies a simple defect, for example, as an atrial septal defect, a moderate complexity defect such as tetralogy of Fallot, and a more complex defect such as a Fontan or single ventricle patients or unrepaired CHD. What they also took into consideration was, in addition to anatomic complexity, physiologic complexity is also important. So adding factors like presence of arrhythmias, presence of aortopathy, presence of severe hypoxemia, presence of pulmonary hypertension will make even a otherwise moderate anatomical defect more complex. So our understanding of that has evolved over time. In terms of strictly pregnancy, how we classify and risk stratify patients, there are three main scores that we discuss, risk scores that we discuss in our paper. One is the modified WHO classification, which grades cardiac defects in pregnancy from grade 1, 2, 3, 4, depending on what outcomes are expected. Then that's one score. The other score is the CARPREG score. The CARPREG study, which is a big cardio-obstetric study, included a large number of congenital heart disease patients as well. So that's one score that we use, which includes various anatomical as well as physiologic factors. And then the third score that we use is Zahara score, ZAHARA, which is based on a congenital heart disease registry. And we use three scores. We use all three scores in patients. And there have been many studies that discuss the use of one score versus the other. And I think you have to use the score depending on each patient and try to get the best risk score that you can for the individualized patient care, keeping in mind the anatomical as well as physiologic complexity of the patient. So that would be how we risk stratify patients in general for congenital heart disease.
If I can ask a question, so is there a risk so high that when the patient presents to the clinic, you go, oh no, my God, and you would recommend termination of the pregnancy, or do you always try to carry the baby even in the very most horrific, complex situation that you encounter?
Yeah, that's an interesting question. So when you talk about risk stratification, the highest risk classification you can get is a modified WHO class 3 or class 4. These are the highest risk patients. Now, traditionally, anybody in these risk scores would be recommended against pregnancy. However, our understanding over the years has evolved. And when you look at more contemporary literature, our discussion is more nuanced than that. For example, within the ambit of diagnosis that come into WHO 3 and 4 are also diseases like systemic right ventricle, which are transposition patients with systemic right ventricle, L transposition patients, which is congenitally collected transposition with systemic right ventricle. It includes patients with single ventricle Fontan circulation, and it also includes Eisenmenger patients. Now, within these, if you look at all these diagnoses one by one, and you look at more recent studies, I would say 2017, 2018 onwards, you would see that reasonably sized studies have shown that pregnancy is reasonably tolerated in those with systemic right ventricle and Fontan circulation. So the outcomes in general for the mother are not that bad, which is to say mortality is rare, even in these diagnoses. These women, even those with systemic RV and Fontan, even though the mortality is low, they continue to be at high risk of obstetric complications like postpartum hemorrhage or even fetal complications. Carrying pregnancy to term is rare, but is not rare, but there are risks associated such as heart failure and arrhythmia as well. But mortality is rare in these two conditions.
So it's fair to say...
The highest risk conditions, coming to that, the highest risk would be somebody with severe hypoxemia and pulmonary hypertension. And if you combine those two, you get Eisenmenger syndrome. So pulmonary hypertension, severe hypoxemia gives you Eisenmenger syndrome. Those would be the highest risk patients where you make that sign what you just did, and you think of what can we do to mitigate risk. In these patients, the risk of maternal mortality is about 30 to 40%, depending on which study you look at. And those are very high risk, and the chance of having carrying pregnancy to term is only about 15%. So I think those are the highest risk patients, where sometimes the risk benefit is not favorable for maternal mortality.
So that's the subgroup that you would at least consider counseling to the parents about the possibility of termination and whatnot.
That's right.
But it's fair to say from listening to you that under the care of experts, most patients can be carried through pregnancy, which is something that is very important to tell people, because there was a time when it was thought that many of these patients should be terminated early on because people were even scared of carrying them through pregnancy. So I
that is right. That is right.
It's a very important message to give.
And I think a key thing that you said right there, Dr. Quinones, is that this should be under the care of a team of experts, a well-oiled team that can respond in a timely fashion to the complications to improve outcomes. Yeah. So, Dr. Rodriguez, tell us, what's your general approach to the management of patients with ACHD? When a patient comes to your clinic from the pre-pregnancy counseling, preconception counseling that we all dream of and advocate for, to getting a team together and aligning the stakeholders that will support the patient through pregnancy. How does that work in your team? And tell us, what are the most frequent challenges you encounter, clinical and otherwise?
Okay, well, thanks for having me here. To answer the first questions, I would say, obviously, we dream of having a pre-pregnancy or preconception counseling where you can stratify, doing some tests that we use in our regular practice to know, even if the patient has a complex congenital heart disease, how good or how well she's doing, how probably she can tolerate all the cardiovascular changes in pregnancy. And we tend to run few tests that will give us more idea if we need to follow that patient closely, or we need, obviously, if a high risk, we need to see her every trimester. But depending how the laboratory results or the stress test that we love to do before pregnancy give us an idea, probably what complication we may face during the pregnancy. And obviously, in the preconception counseling, we would like to talk if she's ready to carry a pregnancy or if not, and what alternative that patient could have. On the other side, the patient came already pregnant. I think it's important to understand and make the patient understand what are the risks, not only as my colleagues say before, that can have arrhythmias and heart failure, what are the risks also to lose the baby as well, lose the pregnancy. So I think that definitely we can try to get those patients, especially the ones with congenital heart disease and complex heart disease, in care before taking the decision of carrying a pregnancy. That will be perfect, because give us an idea that we can prepare her and the family and everything to do that. If that doesn't happen, then we need to obviously run not all the tests that we love to run, sometimes imaging and things like that. We may do more simple things like the echo labs, and then probably see those patients more closely. And I think that's the success of a pregnancy in a high-risk patient is follow them closely. And as you mentioned before, with a multidisciplinary team of specialists between the cardiologists, the high-risk obstetrician, and obviously anesthesia, and everybody involved, social work if it's needed. All of that can make a big difference for those patients. And then I think to answer your second question, what is my biggest challenge with this patient, is when we see a high-risk patient that haven't been followed in our care or lost care, and comes to your clinic pregnant. How do you first make a diagnosis and make sure that she's fine to carry that pregnancy? And if she wants to carry it, make sure that she understands, and the family as well, what are the risks of her having the pregnancy and what potential complications she may face. So definitely, we as a cardiologist, we want to make sure mom is fine, but obviously understanding that she is in the illusion of being a mother. So definitely we need to take into account what we do can affect the baby as well. So I think that will be the biggest challenge when we do cardio OB practice, like understanding all the risks that they may face, even in the best scenario that we have the technology now and all of that, and it has improved in the last few decades. So
one question that I have is, with all the life changes that we're seeing, and increased obesity and increased diabetes and hypertension, even at younger age, how often do you see a pregnant woman with adult congenital that in top of that has diabetes or high blood pressure? I mean, has some of these other adult diseases that we're beginning to see more and more in younger people. Is that common? Is that uncommon? And what happens? Is that a nightmare? I mean, how do you manage all that?
Yes, we see that combination too often, unfortunately. Too often? Yes, too often. And I think what Dr. Rodriguez was highlighting, when you meet these patients before pregnancy, you have an opportunity to address what is modifiable. So if patients that are very obese, we can work on the weight, we can optimize the blood pressure. If the congenital conditions, we can optimize, sometimes they need a valve replacement before surgery. We can optimize medications, see what, if they have arrhythmias, get them under control, see what medications work for that patient. I always explain to them that it's better if we optimize risk across the board, everything we can, the congenital issues and the acquired issues. But we do see this combination very frequently in the setting of pregnancy and childbearing, but also in regular practice. So
yeah, it reminds me, one of our mentors used to say, just because you have congenital heart disease does not save you from getting acquired heart disease.
Right. Yeah.
Yes.
And I think many of our patients tend to be more sedentary than what they should be, because they were told that they cannot do exercise, or they are afraid to do that. Right. So actually, when they become pregnant, then that can be a big issue. Yeah. So definitely, we always say it's like a marathon of 9 months. So it increasing heart rate, dropping blood pressure, so all of that. So it can be a big...
I'm not going to ask the hardest question, or maybe we'll leave it for subsequent. But we have been emphasizing the importance of a team of experts. And unfortunately, there is still a lot of deficiencies in the country in terms of availability of those teams. And I'm sure that this has to be a major issue that societies and groups are looking into, because if you're in some sort of a small town where these things are not available, and you're a cardiologist and you're faced with a woman that has these conditions and is pregnant, you go like, oh my God, what do I do? So, I mean, that's I don't think we have a solution today, but that's clearly is one of the has to be one of the major challenges that we have now.
And I think there is a lot of advocacy going on right now to increase the training programs, formalize the competence levels and things like that, and expose general cardiology fellows to pregnancy and cardiovascular disease and the management education. But it's very hard. I think it's important for the community to identify the centers of expertise, and then I think there is a lot of benefit in that interaction and symbiosis. We work with cardiologists from the community. Patients that live far, I always tell them we need somebody local, and then they come to see us, and we try to work to make an itinerary to facilitate OB, MFM, cardiology, anesthesia, testing, etc., to facilitate that.
Until we get there, which might take us a few years, is there room for telemedicine in this? To have the experts be able to assist the doctor who is in a smaller community? Is that something that is being thought of or developed?
Yes. Telemedicine always helps. I think it cannot replace, especially our obstetrics colleagues. They need to do their scans and monitor the growth and things like that. So there is more collaboration there, potentially. But telemedicine really helps in the postpartum and also in less complex disorders. But postpartum, women who have a newborn and need follow-up at 2 weeks, 1 week, and we're trying to diurese, get the blood, make sure the blood pressure is fine. It's very hard for them to come to the hospital. So telemedicine has been a great success in the postpartum.
But and I was also thinking telemedicine with the doctor, not necessarily with the patient.
Yes. So I think that I think that is a great structure to think about and work on. Yes.
All right.
Yes.
I think you're switching topics now,
we're switching topics, yes. So Dr. Krollmeyer covered a very, very complex topic, the spectrum of ischemic heart disease throughout a woman's life cycle. So when I asked her to write this paper, she had the courage to take it on, and honestly, she did a phenomenal job covering. I really enjoyed her article and invite everybody. It's very hard to find a summary of this quality. So Dr. Krollmeyer, this is a hot topic these days, but it's not really a new topic. Could you enlighten us and elaborate on how the diagnostics and management of non-obstructive syndromes in women have evolved over the last decade, and give us some tips for our clinical practice?
Absolutely. First of all, I want to thank both you and Dr. Quinones for allowing me to be here. This is a very broad topic, and there's tons of literature out there. If you look at my article, there's 80 references in there. What I really wanted to do with this article was to bring it to the clinicians so that it was easier for them to understand these non-obstructive syndromes. Because you're right, we've known about these non-obstructive syndromes since the Women in Ischemia Syndrome evaluation trials, which were done in the late 90s, early 2000s. But we were thinking about it wrong. We were thinking more based on the anatomy than on the coronary function. So we had to transfer our whole thought process from what it looked like to how was the coronary artery anatomy actually responding to different things. And you know, this whole non-obstructive syndrome in women, it's also the story of imaging. Because honestly, in the very beginning, all we had was caths, so that's why we were kind of stuck on the anatomy. We didn't have all the non-invasive tools that we needed, like heart scan and CTA and PET scan. We didn't have any of that, so we really didn't know anything about the coronary microvasculature. We really didn't know anything much about vasospasm. We really didn't know anything really about SCAD or what was causing SCAD. So a lot of this has evolved as the imaging tools have evolved, and now, like I said, it's a huge topic, and it's actually made its way to the guidelines, which I'm very thankful that it has. In the article, I tried to break it down across the women's lifespan because it varies, and we know that there are a lot of things that make it vary. One is just the hormonal changes. For example, SCAD, that occurs in younger women. We've correlated it with birth control pills. We've correlated it with hormonal therapy to assist with pregnancies. We've correlated it with going through menopause. So we know that just the changes in the hormonal milieu is just enough for those people who are predisposed to have spontaneous coronary artery dissection for their coronary arteries to tear. So, and who are those people who are like predisposed? Well, we know that the big majority of them are those with FMD or fibromuscular dysplasia, and we also know that there are also people who have underlying genetic arteriopathies. So this is very important in the pregnant women, because SCAD even in the non-pregnant women looks very different than SCAD in the pregnant women. SCAD in the pregnant women is much more lethal, and so the morbidity and mortality looks much, much different in the pregnant woman. So we delve into that just slightly in the article to discuss those differences, but it's pretty much just the outcomes. The next set that we hit upon was coronary thrombosis. Again, this is another thing that complicates pregnancies more often than any other time during a woman's lifespan. And again, we think that's just because they're more thrombophilic. They have more coagulation factors, they have more DVTs, they have more PEs, they have more coronary thrombosis. So this is something also to look at in that pregnant patient. But I want to say still, the most important cause for ischemic heart disease in younger women, which we define as women less than 50, is still obstructive coronary artery disease. And I think that that gets missed over and over and over again, because we all look at this beautiful young woman and we're like, there's no way that she can have obstructive coronary artery disease. So I always say that the most important factor for women is diabetes. So if that beautiful young woman has diabetes, that increases her fold by increases her chance of having obstructive coronary artery disease by 5 to 7-fold. So we just have to assume that if she's presenting with chest pain and her cardiac enzymes are positive, that she has obstructive disease until proven otherwise. And I think that's pretty much most of them that we discussed. We do go through the whole process of looking at the coronary microvasculature, which is another really hot topic, because now that we have PET and we can actually measure myocardial blood flow, it's something that we can also diagnose. We used to always think that women just presented with chest pain and it wasn't their heart. But again, we weren't thinking about it correctly with respect to the coronary, you know, we were thinking of it with respect to anatomy, but not functional coronary anatomy. So that coronary microvasculature also can vasospasm, and literally that can show up as EKG changes or a nuke defect or a PET defect, and you take them to cath and you see nothing unless you do that functional reactivity testing.
So microvascular disease for many years also was a wastebasket diagnosis. We threw it in when we had nothing else to tell a woman that was having chest pain, and we had already done all the tests, and all the tests were normal. But now we do have the tools to diagnose it. As you said, we have PET, which allows us to really document that the patient has impaired coronary reserve despite having normal anatomy. So now that we have a mechanism, a tool to diagnose, how do we treat this? Because that has been another challenge. We have not had any really major medications for treating this. So
Yeah.
what are your thoughts on that
So
one?
you're absolutely right. There are a bunch of trials that are ongoing trying to figure out what the best treatment is. Most people for the microvasculature, they'll start with a calcium channel blocker, a dihydropyridine type calcium channel blocker like Procardia or amlodipine. And if that doesn't work, then they're going to resort to something like nitrates or ranolazine to try. But honestly, we don't have the answers. We don't know. That trial is ongoing, and hopefully we will in the future.
The outcomes are supposedly more benign than with obstructive disease, but how benign are they?
You're absolutely right. When we look at non-obstructive syndromes, there's somewhere between somebody who has obstructive disease and somebody who has no disease. So, and now in the era of CVCTA, and somebody with non-obstructive disease, their outcomes are the same as somebody with single vessel obstructive coronary artery disease. So like I always tell everybody, imaging is what saved women, and imaging is what decreased women's risk for death due to cardiovascular disease, because it allowed us to pick up subclinical stenosis with respect to the coronary artery calcium score, so that we could make sure the women's got the statin and the aspirin that they needed. And it also allowed us to look at the lesion characteristics on CVCTA, so that we could also make sure that they would receive the therapies that we know make a difference.
So we're going to go now from small little arteries, which are the coronary arteries, to big arteries, which is the aorta. And although aortic disease in women, younger women, and during pregnancy and so on, is a relatively rare condition, when it happens, it can be a nightmare for both patients and the doctors taking care of them. And Dr. Duarte, there's a rumor that you know a little something about that. You even wrote an article in the journal. So teach us a little bit about this condition, which is such a difficult condition to manage when it happens, even though it's not that common. Thank God. Thank God it's not that common.
Yes, it's these are rare disorders in the big scheme of pregnancy, but tertiary referral centers like us, we deal with them often enough, and I think the most important thing is to have a timely diagnosis, to have a diagnosis of aortopathy. It's the worst case scenario is to diagnose aortopathy in the setting of pregnancy due to an aortic dissection, and so the way I think education is key to this, because every time there is a patient with newly diagnosed aortopathy or dissection, these patients need to be counseled to have their first degree relatives screened, because we have been able to identify many patients and diagnose them earlier thanks to the counseling of their family members. So right now the guidelines, the 2022 guidelines, recommend that all family first degree relatives of patients with aortic disorders should be screened regardless of their genetic testing results. So they should be screened with imaging. And I try to be very straightforward when I counsel them. I usually ask them about their family members, identify a center where they can be tested, and recommend an imaging modality too. And that has helped us. That's helpful to when a patient presents and has a diagnosis, and then that pre-pregnancy counseling meeting where we get an opportunity, a golden opportunity to assess, risk stratify, obtain imaging, see what's the status of the aorta. Do they have an indication for surgery, prophylactic surgery, proactive surgery before pregnancy to decrease the risks? And for example, in the Marfan population, Marfan women with aortas that are under 4 centimeters, the risk of dissection is low. But when the aorta measures over 4.5, then the risk is significant. And so those patients may benefit from intervening in the aorta before pregnancy.
So do you counsel them against pregnancy until something is done?
Yes, we work here very close together. A very frequent phone call is when I identify this patient who I do not want to get pregnant before we address the issue. So I communicate with the OB team. We get them in right away to ensure reliable contraception. And I discuss this with my patients. I tell them we are in the process of decision making and risk optimization. We have to be very sensitive when we talk about fertility with women, and while we go through this journey, we need reliable contraception. And as a cardiologist, I investigate what they're using for contraception, and I identify the patients that need to be seen and addressed right away.
So one of the medications that is often used for prevention once you have an aortopathy is beta blockers.
Yes.
So now the patient is pregnant, but beta blockers are not too good during pregnancy. So how do you handle that one?
In pregnancy, everything is a matter of perspective. So I have this discussion all the time with my patients. It's very hard to find medications that have a green light for pregnancy, but then we always discuss risk and benefits. So in patients with aortopathy, the recommendation is to continue beta blockers during pregnancy. And in our MFM and high-risk OB team, they are very supportive at monitoring the fetal development. There is a risk of having lower weight, but in general that doesn't have major consequences otherwise for the baby. So we discuss that when we meet the patients pre-pregnancy, just like arrhythmias and heart failure and all valve disease, we discuss the medications that they will need to take during pregnancy. We discuss the risk benefit, and I make sure that before they embark themselves in pregnancy, they're willing to accept the therapy that we're recommending.
I'm glad that you are here with us, taking care of that. All right.
It takes a village. I don't do it alone. We're like 40 people that meet and discuss and try to get to a consensus to make it work for this.
All right, looks like we're going to be switching to another very important topic too, right?
Yes, that's right. So Dr. Velarde, she took on another challenge, covering sex disparities in cardiovascular disease. And Dr. Velarde, I just want to hear your thoughts about how have we evolved in sex disparities, in addressing sex disparities in cardiovascular disease. Are we meeting the needs of the times, or we're falling short? And what would your advice be for the new generation of cardiologists that are watching us to make sure that we embrace change and we take action? We cannot hear you, Dr. V.
Thank you. Thank you for having me. And it's an honor to be sharing the stage with Dr. Q and seeing how much we've covered already in this conversation of this wonderful edition. Our task with our portion of the edition was to really give a 10,000 feet view of what the landscape looks like. And to answer your question, we need to really have that approach. Every time we dwell into a paper, a manuscript, and do the due diligence of the research, we see that we have to learn something. And from this exercise, my colleagues and I, in this particular piece, really learned that disparities in women's cardiovascular health exist in every subspecialty of cardiovascular disease. So that is a theme that it's important to recognize, that currently we still have these disparities, whether we're talking about congenital disease and pregnancy, which is something very unique to women, but whether we're talking about ischemic heart disease and risk factors, the recognition of risk factors, and the importance of inclusion of women in trials and in all aspects of the study of cardiovascular disease. So I think that our view is that whether you look at and reinforced by the research to write this portion of the manuscript was that, they're still very prevalent. There are differences and there are disparities, and there's a difference in that definition that it is important for people to understand, because differences really relate to the biology differences that do exist, but the disparities are a little bit more profound and more complex that really start to penetrate and worsen many of the differences that are not acknowledged and that involve a layer of complexity that has to do with systemic factors. So where are we was your question. We have improved, but let me just take a step, a pause for a minute, and to see how many here in the audience have gone to the ACC that we just were recently, right? We had a national conference that had some late-breaking trials, and I was looking at some of the late-breaking trials, and the inclusion of women in some of those late-breaking trials is still dismal. IMPACT-MI, which was a negative trial with empagliflozin, a SGLT2 inhibitor, and the effect in myocardial infarction, only had a 24.9% women inclusion. REDUCE-MI, which was a beta blocker study, only had 22.5% women included in that trial. Actually, the DEDICATE study, which was a valvular study with TAVR versus SAVR in low risk population, that was done in Germany, and the Germans did better. It was 43% inclusion. So my point here is that for us to move the needle forward and to decrease these disparities and understand the differences, we really have to have a comprehensive, multifaceted approach. We need to include all women of different ethnicities in these trials. We need to investigate and do the research and include sex as a basic cell format from the beginning. We need to educate our professionals and our providers and some stakeholders, and we really need to advocate to optimize, a public policy and optimize care. And finally, like Dr. Nanette Wenger says, we also need to legislate to ensure that there's health equity, because even within the sex differences and sex disparities, there are racial and ethnic minorities that are affected more by a complex interplay of the social determinants of health that really impact every aspect of what we discuss here today. So we try to woven in that in our piece, and I recommend our readers to go to this edition because it's wonderful. It has all the topics that we discussed, and it really tackles all these issues, and with the word limitations that we have to abide by. But it was a wonderful exercise, and I cannot thank you enough for giving us the opportunity to be part of it.
I have a question that I don't know if you can answer, but as I was listening to you, it just came to my mind. When we look at other fields in medicine, and I'm thinking of two big ones in particular, diabetes, for example. So clinical trials in diabetes are usually done by endocrinologists, and clinical trials in cancer are done by oncologists. Do we see the same problem in those other areas as we see in the cardiovascular field, or are they doing any better than we? And I'm partly asking the question because I think we still have a challenge in having more women in cardiology. So I'm just wondering whether that disparity exists in these other areas of medicine, in the clinical trials, just as the same as in ours, or are we a little bit more behind the 8 ball than they are? You know the answer to that?
That is a wonderful question, and I'm sorry, I cannot answer with certainty regarding endocrinology. I do know that oncologic trials, for example, is very much driven by the type of a neoplasm that drives the study. So it would be interesting. Obviously, breast cancer, it affects, obviously. So
Sure.
it's more driven by who has the disease. But it would be interesting to see if we see the same for lung and GI neoplasms. Now, for
because you go to the oncology world, and there is a fair amount of women involved.
That's right.
And diabetes is almost, in fact, diabetes is the opposite. It's almost all women now. There's a high penetration of women physicians in diabetes. We're still struggling. I mean, to be honest, in cardiology, we can do better.
We're struggling, and and every single one of our subspecialties. When you look at valvular disease, and we have difficulty making the diagnoses. We have low flow, low gradient. We don't know. We even with MR, accounting for the size of the heart and the volumetrics that affect women because of the smaller hearts. In ischemic heart disease, as it was so eloquently presented previous to myself, I think that we're struggling, and we continue to struggle. And seeing those numbers on those late-breaking trials it's still painful for me to watch.
Yeah. Well, we're coming to the end, and there were several topics that we would have loved to cover, but we don't have the authors here, so Dr. Duarte is going to try to give us a brief summary of all of these topics. I suspect she's going to primarily try to invite all of you to go to read the articles in the journal. But
That's right. So yes, we have our authors. We are very grateful to our authors who are present today, and also our authors that were not able to be here. Dr. Laith Al-Shawabki from University of California in San Diego, and his team wrote a marvelous article about valvular heart disease in pregnancy, tackling all the higher risk conditions and giving very, very useful clinical tips to manage these patients and approach them when we see them early enough. Dr. Kamala Tamirisa covers arrhythmias during pregnancy. She is a declared expert in this arena, and she and her team put a great graphics together to summarize what can be used and what not. Dr. Cindy Martin, the chief of heart failure in our department, covered cardiomyopathies in women, including advanced heart failure therapies and the disparities there. Dr. Safdar covered pulmonary hypertension in women during pregnancy and otherwise. Dr. Safdar supports us when caring for these patients, especially patients with CTEP. And then Dr. Nasser and Dr. Eleonora Avenatti put an excellent article together on prevention efforts in women, so they don't get to the obstructive disorders that Dr. Kerlmeyer was highlighting earlier. We are very grateful to our authors for all the time they have dedicated, and we invite all of you to take some time to review this state-of-the-art pieces, and we are thankful for your presence, for joining us today, and we look forward to meeting you in our next issue, Dr.
Right,
Q.
and our next issue will be in pulmonary embolism. It should be coming out in May, and we look forward to seeing all of you in another webcast on that particular issue. I want to again thank very dearly Dr. Duarte for putting all of this together, and of course all the other participants and all the authors. So have a wonderful evening with your family, hopefully. Have a good dinner. And we'll see you in about 3 months.
Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.